So it's a pleasure to continue today's proceedings. We will now be awarding the Curtin Medal for Medical Research to Professor Gershon. So before we do that, I'd like to make a few comments and to give people somewhat of a background on Professor Gershon, whom I've known for many years. So Professor Gershon is this year's recipient of the Curtin Medal for Excellence in Medical Research, and we find that he's eminently deserving of this award because of his exceptional contributions to basic clinical and translational research in psychopharmacology over more than half a century, and for his remarkable achievements as a teacher, mentor, and guide to several generations of researchers in the field, many of whom continue to consult with him and ask for his guidance and expertise. Professor Gershon was educated in Sydney and attended the University of Sydney, where he received his medical degree and specialist training in psychiatry. He was the professor and acting head of the Department of Pharmacology at the University of Melbourne, and while there he also trained a substantial number of very notable individuals. His strong preclinical background explains his integrative and translational approach that has been a hallmark of his research philosophy. In Melbourne, Professor Gershon worked closely with Trautner, producing a series of important papers, and their pioneering studies in lithium included the use of plasma lithium levels monitoring to prevent toxicity and to define therapeutic range. In 1963, Sam Gershon moved to the US and began an exceptionally productive career that really was very inspiring to many people who worked with him. He was the head of the New York University Neuropsychopharmacology Research Unit, which became truly legendary. And those who worked at this unit, and I still hear to this day people commenting about that period, and who either worked there, passed through, or did sabbaticals, attest to this day to the air of scientific excitement and innovation. In 1973, Sam Gershon published the first textbook on lithium, called Lithium, Its Role in Psychiatric Research and Treatment. He took up the position of chairman of psychiatry at Wayne State University in Detroit and director of the Lafayette Clinic in 1979. And in Detroit, he continued his pioneering contribution to psychopharmacology as a facilitator, guide, and a mentor. In 1988, Sam Gershon moved to the University of Pittsburgh, where he took up the position of Associate Chancellor for Research in the Health Sciences for all of medicine. At a stage when many would be content to rest on their laurels and to do some administrative work, he remained an exceptionally active scientist and mentor. His research interests focused on alcoholism, related issues, and also expanded to the adolescents and to the elderly. He was very active in developing magnetic resonance spectroscopy, and returning to his earliest and most enduring interest, he contributed to research on bipolar disorders. He co-founded the journal Bipolar Disorders, which is very highly ranked now and continues to edit it, and he also has served as president of the International Society for Bipolar Disorder. 3 years ago, he was living in Miami, and I recruited him to be Professor of Psychiatry and Vice Chairman for Academic Affairs at the Department of Psychiatry there at the University of Miami when I was chairman. In the course of his career, Professor Gershon published more than 600 papers in relevant peer-reviewed journals, which I find extraordinary is that 10 of them were in Nature and 7 in Science, and more than 100 book chapters and invited articles, and has edited 23 books. As a scientist, innovator, astute evaluator of the field, teacher, mentor, and guide, Sam Gershon has made an impact that has substantially influenced the course of translational pharmacology. He began his career here in Australia and had already made very important contributions before moving to the US. But he has retained a strong affinity to Australia over the years, has trained and mentored many Australian scientists, and played a pivotal role in establishing lithium, a uniquely Australian contribution to medicine, as an important treatment that has prevailed over several decades to the present day. I first met Sam Gershon at the NIH because of his reputation. Where I worked for the longest period of my career, which was the NIH intramural program, was very similar to the John Curtin School prior to 2000. That was like a completely intramural kind of block grant-funded entity. But we had these very vicious external reviews every 5 years. So people who worked at universities and were very jealous that they did not have dedicated money would come, and the agenda was to really kind of be as critical and as destructive as they possibly could. So we organized what we called like a mock site visit. And my branch chief at the time, who was one of the people who was targeted to be severely shrunken, I would be shrinking with him, was Phil Gold, who has a tremendous sense of humor, is very engaged. And so all of these review exercises become like, a big joke, and it starts like, the whole thing escalates and loses its purpose of preparing you for a tough review. So I thought, who could be the chair of this session that would keep Phil Gold in line and would not let this, kind of escalate into a comedy? And people said, bring some Gershon and you'll see. So I brought some Gershon. He was very strict and kept everybody like on their toes. And then we got prepared. And when the external review came, we all survived. And I'm here to tell the story. So I'm very grateful to Sam from that time on. And it's a pleasure to honor you with the Curtin Medal today. You'll get the medal.
I've got to actually put on a show.
Yeah.
Thank you.
So it's a great pleasure to have you here, Sam.
Thank you very much. You taking my papers?
No, this is mine. I'm taking mine and leaving yours here.
I was... just hold on, we'll start this. Okay, not yet. Okay. All right, thank you. Ladies and gentlemen, good afternoon. I'd like to... I appreciate Dr. Licinio's remarks very much, and actually I'm very touched by the greeting I've received in coming back to Australia after many years abroad. And the greeting on my return was really warmer than the farewells when I left. But I am pleased to be here today for many reasons. I want to thank the John Curtin School of Medical Research for this prestigious award. I also want to thank them on behalf of my Australian teachers and mentors, and also on behalf of my American colleagues and friends. This presentation is about a history of the first major step in psychopharmacology. The time course of the development of lithium since its introduction in 1949 is concomitant with the span of my professional career. My role, thus, is of a historian and participant in the evolution of these events. Cade's report, published in the Medical Journal of Australia, did not engender much excitement initially outside Australia. This report, however, heralded a number of dramatic events. It preceded the introduction of chlorpromazine into psychiatry, and in fact fired the first salvo that initiated the modern era of psychopharmacology. Here we have to try and answer this question: when is a discovery a discovery? And what identifies this designation? And what determines the future trajectory in science? Serendipity is one of the many factors that may contribute to discovery. It played a major role in the discovery of prototypic drugs in psychiatry, and lithium may well have travelled this road. Dr. Hickey before mentioned a comment from Dr. Insel about the few new molecules that have been introduced into psychiatry since chlorpromazine. And I think they gave a figure of less than $1 billion for the investment. I would guess that it's multiple billions of dollars that have been spent in the investment of new drug discoveries. And when you look at them, the ones that we have, many of them are Me Too compounds. They are not true breakthroughs in most cases. And therefore we have a real necessity to go back to basic neuroscience and get a transitional approach back and forth from the clinic back to the laboratory. Here we have a sort of a comings and goings of lithium over time. You will see that the first mention is Alfred Garrod, who introduced some claims for lithium use in general medicine. Weir Mitchell in the United States also made some very generalized claims, but it was not till William Hammond in 1871 in the United States who made a claim for lithium specifically related to its use in psychiatry. The other people that also made specific relevance in psychiatry were the Danish group of Carl and Fritz Lange. So this occurred towards the end of the 19th century, and then we move to the classic event of John Cade in 1949 with some other reports that are mentioned up there. There are a couple of others in the Australian list that in this report didn't get any mention, and I'm looking at my colleague here. He shares the guilt with me that there were two other interesting Australians, Glessinger and Margulies, who wrote papers of small sample size, no controls, one in Tasmania and one in Western Australia. But really, in the big cities of Australia, there was no big response. And there was no big response around the world till we see the work that was started in the United States in the late 50s, early 60s, and then the important work of Scow and his group also in Denmark. But as you will see, in the US there was some political activity in 1968 and 1970 with the APA task force, who gave a report that tried to stress the importance of looking more carefully at lithium. Until 1970, there was an FDA approval for its use only in acute mania. Now, here in our discussion of lithium, we encounter a compound that has appeared in the medical literature at least since 1859 in a textbook by this gentleman, Sir Alfred Garrod. He discovered uric acid in the blood of gouty patients. The use of lithium was prescribed on the basis that it would treat the uric acid diathesis associated with gout. Also the notion that recurrent gout could cause both mania and melancholy, and this was carried over into the 19th century. Garrod reported that within the last 2 years, I have made many trials of carbonate of lithia as an internal remedy in cases of the uric acid diathesis. Garrod claimed that the lithia salts can scarcely be said to have been employed therapeutically until recently in 1858, and, as he adds nonchalantly, by myself. Many lithium compounds were listed in Merck's index from its first edition in 1889 until 1940. Then, in 1941, the Extra Pharmacopoeia denounced them, stating that their introduction into medicine was due to misconception, and there is no rational foundation for the use of these salts. And it's important to stress that in the classic American textbook of pharmacology by Goodman and Gilman, this was the position taken in the 1950s and 1960s editions of the textbook. So this discovery phase really only became a background story among the vast array of claims and uses for lithium during this period. However, we move on to some more specific uses and claims for lithium in psychiatry by Hammond in New York and the Langer brothers in Denmark. Hammond, like many of the people associated with this story, was a very remarkable character. He was at one time Surgeon General of the United States Army and later Professor of Diseases of the Mind and Nervous System. William Hammond, an alienist at the Bellevue Hospital in New York, was possibly the first to have reported in 1871 the use of lithium as the bromide in the treatment of acute mania. According to his treatise on diseases of the nervous system, which was translated into both French and Italian, he describes the condition as acute mania with exaltation or acute mania with depression, very much like the later classical descriptions of manic depressive disorder. And Hammond speaks for the first time in this literature specifically about dosage. He also emphasized that the doses should be large, namely as high as 45 millimoles of lithium or even more, and repeated every 2 to 3 hours as a loading dose and later reduced. We'll come into a discussion of this aspect of his pharmacological description when we talk about electrolytes in the handling of lithium. As Hammond did not mention the use of lithium in his later works of 1882 and onwards, one could speculate as to whether he had ceased using lithium due to toxicities from the high doses he administered. From his clinical descriptions, it might appear that he was reporting some specificity for the treatment in manic states. For whatever reasons, lithium departed the scene and was forgotten. Not quite because of the Langer brothers. This Danish aspect of the story has been meticulously researched by Dr. Johan Scholden, who was born in Denmark and is now Emeritus Professor of Psychiatry at the University of Adelaide. That's not his picture. This is a picture of Carl Langer, a neurologist who was famous for his contribution to the James Langer theory of emotions, published in 1885. Frederick Lang, his brother, was a psychiatrist. In 1886, Carl Langer delivered a paper to the Danish Medical Society on periodical depressions and their pathogenesis. Both brothers treated these periodical depressions with lithium carbonate. Their thinking was that these periodic depressions occurred within the constructs of the still prevalent uric acid diathesis. Within their thinking was a belief that auto-intoxication was involved in the etiology of the illness. In summary, the Langer brothers must be credited for a clinical description of periodic depression which was recurrent, remitting, and long-lasting. Further, that it may have a heritable or familial relationship and was of an organic origin. They strongly maintained that the treatment should be continued beyond the current episode, and fundamentally proposed its therapeutic value as maintenance treatment. Thus, prophylactic pharmacotherapy was first envisaged in psychiatry. However, like many good stories, this story did not end well. The Langers presented their work in Danish, and thus it was open to a limited audience, but with some translations into German. A number of Danish psychiatrists questioned the clinical concepts of periodic depression proposed by Langer. Kraepelin also joined this discussion with his own critical view of this disorder in his 1904 and 1927 editions of his textbook. Kraepelin was perhaps the most important psychiatrist in Europe at the time. So we see that there are wars relating to diagnostic classification going back at least to that time, and it seems to be ongoing when we're facing DSM-5 now, and you read at least some of the American papers, even in the sort of more universally distributed non-scientific papers, that the two sides in the argument are ready to kill each other. But a DSM-5 will emerge, and we will have to live with whatever's produced. Now, lastly, criticisms of the whole concept on which the lithium treatment was based, the uric acid diathesis, criticisms were offered at a meeting of the Medical Society in Copenhagen in 1911. Thus, these events removed lithium therapy from the arena for about 50 years, and it was again dismissed and forgotten. From our current perspective, I think we can conclude that their work on periodic depressions made a significant clinical contribution to later constructs of mood disorders. Their use of lithium as a treatment for mood disorders could be characterized as serendipitous, as it was based on the false assumptions of the uric acid diathesis theories. Now we come to a more recent phase of this trajectory, with the appearance of John Cade. To your good health. John Cade was the superintendent of Royal Park Receiving Hospital in Melbourne when I came there as a first-year resident in psychiatry in 1952. John Cade was a remarkable man from many points of view, but one of which really must have marked him for life was the fact that during the Second World War, he was a medical officer, was captured by the Japanese, and spent 4 years in a Japanese prisoner of war camp in Changi. After he came out of the war, he immediately resumed work as a psychiatrist in the mental health system in Victoria, and lithium was introduced in his paper in 1949. And one must understand the climate in psychiatry at that time. It may be difficult for many younger colleagues to even comprehend this picture, which was much the same in the US and Australia. My experience in Australia at 2 large chronic state facilities was of about 500 patients, with myself, 1 other resident, and 1 superintendent. The treatment armamentarium was sedatives, ECT, and insulin. Cade's clinical paper in 1949 was preceded in 1947 by some animal studies he carried out in guinea pigs, and his assumption that manic depressive illness is analogous to thyrotoxicosis and myxedema. He hypothesized that mania is a state of intoxication by a normal product of the body in excess, and melancholia is a state of deficiency of the same substance. It is interesting that we went through a phase where the same thing was said about norepinephrine and manic depressive illness. To test his hypothesis, he compared the effects of IP-injected concentrated manic urine with concentrated urine from normal subjects into guinea pigs and found the former more lethal than the latter. There have been similar beliefs in more recent times on abnormal substances in psychotic patients, with the examples of adrenochrome by Hoffer, the pink spot in urine by Friedhoff, taraxine by Heath in New Orleans, the Lafayette Clinic studies in schizophrenia, of which we will not say anything about, and Ackerfeld ceruloplasmin in schizophrenia in Sweden. The interesting thing is that none of these discoveries have survived. Cade went on to determine the toxicity enhancing effects of uric acid, and used lithium urate as the most soluble of the urates. To assess whether lithium salts alone have any effects, Cade injected large doses of 0.5% aqueous solution of lithium carbonate IP into guinea pigs and found that after a latent period, the animals became extremely lethargic and unresponsive to stimuli for about 2 hours. It is possible that this lethargic state was due to lithium toxicity. It may seem a long way from the lethargy of guinea pigs to the control of manic excitement. However, he then moved directly to a clinical trial of lithium in 10 manic, 6 schizophrenic, and 5 depressed patients, an open study, no controls, no significant sample size. He concluded that lithium was effective in all 10 manic patients and reduced overactivity in the schizophrenics and had no significant effect in the depressives. Thus, once he undertook the clinical use, his observations were remarkably accurate. One case subsequently died of lithium poisoning. Cade did not have available the monitoring of blood lithium levels. It is interesting, however, that Cade never again undertook any studies with lithium, nor did any of his predecessors that we've mentioned up to date. He published a number of review articles, but never pursued the many interesting possibilities his work opened up. However, he did attempt to offer explanations of the therapeutic actions of lithium. His views appear to have been modified over time. In a 1970 paper, Cade stated, "It may seem a long way from lethargy in guinea pigs to the control of manic excitement. But as these investigations had commenced to demonstrate some possibly excreted toxin in the urine of manic patients, the association of ideas is explicable. Another proposal was that lithium may well be an essential trace element and leads to the speculation as to the possible etiological significance of a deficiency in the body of lithium ions in the genesis of this disorder. However, the conclusion must be that whatever inclarity existed in Cade's preclinical work, once he observed the effects of treatment on patients, he was uncannily prescient. He felt that it exhibited a remarkable specificity for the manic features, that it was not sedating to patients, and that the treatment could be continued with a possible prophylactic benefit. This clinical report by Cade heralded the third revolution in psychiatry, psychopharmacology. Again, there was an interruption to any replication of these findings because lithium-induced fatalities were reported in Australia by Roberts, by Ashburner and others, including one case of Cade's. Furthermore, according to Cade's colleagues, particularly Dr. Quart and others, Cade was so concerned about the possibility of serious lithium poisoning that he discontinued lithium therapy altogether. This was the picture when I came to Royal Park in 1952. There was no use of lithium in the treatment of patients. This problem was compounded by the reports in the United States of lithium's potential fatal toxicity reported from the use of lithium salt substitutes for sodium chloride in hypertension. In February 1949, the FDA took abrupt action and instituted a recall of all lithium-containing salt substitutes from the market, and this ban remained in place till 1970. Very good Canberra water. It would seem surprising that with the multitude of reports in the old literature on lithium, that the FDA approved lithium chloride as a salt substitute in the first place. So there was a pall over the future use of lithium in psychiatry altogether. To address this issue, my colleagues at the University of Melbourne, Dr. Troutner and Doug Coates, Victor Wynne and Charles Nowak, carried out a number of studies to understand the problems presented and develop treatments and safeguards. These studies made it possible to resuscitate lithium studies and offer a safe way of monitoring long-term maintenance therapy. Now, let me say a few words only about these two gentlemen. I really need to introduce Troutner into this historiography, as well as the name of the chair of the department, Professor Wright. Professor Wright was a champion of academic principles and prerogatives. Professor Wright was also a member of the Council of the Australian National University, and he also became later the Chancellor of the University of Melbourne. And he was an exceptional man because, let me sort of a very brief story. I was a first-year resident in psychiatry at the time and was interested in a couple of research topics. And as The psychiatry course at that time was given by the university and not by the College of Psychiatry. Our teachers were at the University of Melbourne. So I made an appointment to see Professor Wright, and I went in to see him, and he asked what I wanted to see him about. I told him it was about lithium and one other topic, and we had a chat, and he ended the conversation by saying, "Well, you'll need to see Trouty upstairs on the second floor." And that was my introduction to Dr. Troutner. So I went up to the second floor and saw him, and we developed a series of cooperative efforts over the next 10 years. At that time, Troutner and colleagues had studied Cade's findings, including the deaths that had occurred since Cade's paper. Then they studied 100 psychiatric inpatients with a variety of diagnoses. The important aspect of the study was the introduction of the assessment of blood lithium levels in all their patients. This was done with the assistance of the recent development of flame spectrophotometric assays by Victor Wynne at the University of Melbourne. Dr. Troutner was my mentor and friend for the whole period I worked in Australia. We went on to publish a paper with Coates on the treatment of lithium toxicity and with others on animal teratology. A study of the differential retention and excretion of the lithium ion presented some interesting aspects of the handling of the lithium ion in the manic phase compared with the return to euthymia. Hang on, just a sec. No. I need help here. Okay, am I right? Almost. Oh, yes, sorry. Noack and Troutner's paper of those 100 patients concluded that the very beneficial effect of the drug in cases of mania did not justify the abandonment of lithium treatments. This paper, as was Cade's, was among the 10 most cited papers of the Medical Journal of Australia. Also, this safety monitoring was adopted by Scow and in other subsequent studies in the literature. Scow wrote to Troutner in 1974, saying that it is my firm conviction that the studies you contributed concerning lithium toxicity and the monitoring of lithium treatment through serum lithium determinations were of primary importance for the development of this treatment into a safe and efficient procedure. Our 1955 paper on lithium handling offered a suggestion of lithium specificity with the retention of lithium in the manic phase and increased elimination after mania broke. This report also demonstrated a relationship between plasma lithium level and toxicity and the construct of a therapeutic window. In 1954, Troutner wrote to Scow, "We are very glad to see that you were able to confirm our results, particularly in view of a lot of opposition we meet." That was his view of the reception that we were receiving in Australia at the time. He goes on to say, as to the mania, we find with careful treatment there was a very high response rate. In conclusion of this section, not in conclusion. In conclusion, I need to say that the importance of Troutner's role in both the clinical and basic research done on lithium treatment has been almost completely neglected by history and by psychiatrists. The next important character in this story is Moen Scow. Scow was a good friend and colleague and committed his career to clearly establishing the efficacy of lithium treatment and was a worldwide crusader on educating psychiatrists about the safe and effective use of lithium. It was Dr. Strobgren of Riskov, Skau's chief, who in 1951 had drawn his attention to Troutner and Nowak's paper of that year. All the papers in the literature up to this time had been uncontrolled and thus were open to criticism on those grounds. Skau became concerned that what was needed was a placebo-controlled study. And this trial that he did in 1954 fully confirmed the anti-manic effect of lithium and was the beginning of Skau's lifelong commitment to this work. A number of investigators had observed from their continued observation of lithium treatment in manic and depressive patients that prolonged treatment with lithium might ameliorate or prevent not only manic but also depressive recurrences. And this was established in this particular paper by Bastrop and Skau. Their findings were very impressive. Lithium treatment caused a decrease of 87% in frequency of both manic and depressive recurrences. Before I leave this period, I would like to briefly outline some of our studies in Australia and the US. All of our Australian studies involved Troutner and colleagues at the University of Melbourne. These two open studies, that is the Troutner and the Cade study, presented a case for selective efficacy in mood disorders. Now we had to look at the problem that was a serious limitation to general utilisation of the treatment, toxicity. Our study on lithium handling showed a pattern of retention in the manic phase and increased excretion when the mania broke. Thus, a reduction in dose may be required, and this change in the handling of lithium could account for previous investigation, those of Hammond and others, who encountered toxicity even after therapeutic response was achieved. These studies also established the need for individualisation of dosage. The range of this window has been set currently at between 0.4 and 1.2 milliequivalents per litre. In 1960, we published the first US report presenting a case for the psychopharmacological specificity of the lithium ion. And as Dr. Lucidio mentioned, in 1973, we published a textbook on lithium use in treatment and research. In 1968, my colleagues at NYU initiated a number of controlled clinical studies of lithium and several typical antipsychotic agents. A key finding from these controlled studies was the superiority of the antipsychotics over lithium in schizophrenia and schizoaffective patients. Well, here we came to a very positive phase in the development of lithium therapy, and all seems well. But now we come to what is called the Battle of Lithium, which was the Battle of Britain in 1968. That occurred with psychiatrists from the Maudsley Hospital, Blackwell and Shepherd, expressing their scepticism forcibly in the Lancet in that year. This debate continued, during which the Maudsley psychiatrists did not use lithium treatment. This battle with Britain continued with other salvos from Dr. Joanna Moncrief right through to 1997 and 1998. Although in the meantime, Bastrop and Skau in 1970 had published a double-blind discontinuation study of patients with recurrent mood disorders. Their results were dramatically clear in support of the prophylactic efficacy of lithium. The FDA then gave approval for lithium in acute mania, which did not occur till 1970, and this after only much lobbying and discussion. In 1975, the FDA accepted a claim for lithium prophylaxis in mania, and as of today, it has not accepted a claim for prophylaxis for depression. However, it seems that the Battle of Britain was just a skirmish, and peace has been restored. We are now into the most current phase of this story, with a major contribution again from Britain, called the Balance Study, which was executed by John Geddes and Guy Goodwin at Oxford. This was published earlier this year as a blind, randomised, multi-centre controlled study of 330 bipolar 1 patients assigned to 3 groups: lithium plus valproate versus monotherapy of each. The very important outcome was that both combination therapy of lithium plus valproate and lithium monotherapy are more likely to prevent relapse than is valproate monotherapy. This is irrespective of baseline severity of illness and is maintained for up to 2 years. These findings demonstrate a number of key factors that affect the adoption of different treatments over a 60-year period, with using lithium as one example of changes that occur in therapeutic practice in psychiatry over 60 years. Some of the lessons we learn are that despite the scarcity of good comparative evidence, major shifts away from prescription of lithium have occurred, especially in North America. Prescription of lithium has halved between 1992 and 1999, whereas the rate of prescription of valproate has tripled. The second observation is the tendency to believe that the newer marketed product is better than the old. And 3, intense marketing of a patented product can significantly affect usage of a non-patentable, non-commercially marketed product, even at much lower cost. These are some sort of important lessons that at least psychiatry and perhaps all of medicine needs to look at carefully. In addressing these issues, we must concede that the diagnosis of the illness has been ever-changing and broadening, and makes comparison of clinical findings over time more difficult. With the broader diagnostic concepts of bipolar disorder, therapeutic efficacy of lithium appeared to decline, and the usage of typical and atypical antipsychotics increased. Given the claimed specificity of lithium, this outcome is logical and to be expected. That raises a major set of concerns for DSM-5. And this is an issue which is under current consideration, the diagnostic criteria that will be employed. And it has an even greater concern for the concepts, if they exist, of what is appropriate targeted pharmacotherapy. However, within these constraints, the overwhelming body of evidence permits the following conclusions. 1, lithium has proven efficacious in mania over time. It is a benchmark treatment for mania and the gold standard comparator. It is unique in exerting antipsychotic activity without drowsiness, sedation, hypotension, or neurological side effects. It has an efficacy in bipolar depression. And the next phase is an important one, generally in the concept of pharmacotherapy and psychiatry, prophylaxis in bipolar disorder. Lithium is the unanimous first-line choice for the maintenance treatment of bipolar disorder. It is effective in both manic and depressive phases. Maintenance therapy is the most important aspect of managing this disease. It is not the successful treatment of an episode, it is management over long term. Augmentation of lithium in treatment-resistant depressions is also of considerable value. And then the other findings. Lithium is effective for so-called classic bipolar disorder, which we're not going to define because we'll leave that to DSM-5, but it lacks efficacy in atypical forms of schizophrenia and schizoaffective disorder. And this is the result of Cochrane reviews that have failed to support the value of lithium in schizophrenia and was the result of our 1968 studies at NYU. An important challenge still left to us is to identify the subgroup that is specifically lithium responsive. Now, lithium has some quite unique properties, in addition to what we've been describing, which have really developed over years of observation. One, it is anti-suicidal. The risk of suicide is significantly elevated in bipolar disorder, with a lifetime risk 15-fold the general population. Untreated, 20% of bipolars commit suicide. Lithium is unique in that long-term use reduces the risk of suicide and suicidal behaviour in bipolars by up to 80%. 2, another unique feature are the findings on neuroprotection. Bipolar disorder entails mood episodes as well as considerable structural impairment over time, as Dr. Hickey has observed in his other studies. These changes are potentially secondary to changes in cellular plasticity and resilience. Recent analysis of structural studies in bipolar disorder showed a robust change in brain structure, as well as evidence that lithium increases grey matter volume and valproate does not. Neuroprotection is the most consistent biological outcome associated with lithium treatment in both preclinical and clinical models. In this regard, neuroprotective properties of lithium are thought to relate to the mechanism of action and may be responsible for its mood-stabilizing effects. And now really, in conclusion, lithium was the first unlikely salvo in the revolution of psychopharmacology and psychiatry. The neuroscience findings over the past 20 years are now giving us an insight into some aspects of the mode of action and offer the possibility of new therapeutic approaches which we desperately need. This allows the conclusion that lithium is a well-established therapy that has withstood the test of time and can be classified as a major discovery in psychiatry. Thank you very much.
Yes. No, I just would like to thank Sam for a really wonderfully encyclopedic overview of essentially the evolution of psychiatry research in the 20th and 21st century now. And I'd like to open the floor for questions.
Yes, sir. Speak up loud, because I'm deaf.
Yeah, I've got the same. One of the big worries, though, is the toxicity of lithium on the kidney. I mean, on the thyroid, that's pretty easily fixed. But, now, after a long time in psychiatry, one starts to see these patients who develop chronic renal failure. Could you like to comment on that problem when, on the other hand, we've got evidence that the best efficacy is for lithium?
You're absolutely correct. The incidence is very low, but it does occur. And unfortunately, the only way to deal with not only this particular problem with medication, but with all problems with medication, you have to be a total physician. You have to follow these patients regularly with plasma lithium levels. You also have to follow them when they get a medical illness, because the balance goes out and they can get toxic very easily. You have to know about their neurological state, because if they have neurological damage, they're prone to neurotoxicity. And you have to follow their kidney status, because if their kidney function deteriorates, you have no course but to take them off the lithium. The question of dosage of lithium sort of haunts the whole use of lithium, because I deduce, sort of as an amateur Sherlock Holmes, that all the previous usages of lithium by those brilliant people terminated because people were dying. And I remember here in Australia, when we were using it, we came to some coroner's inquests where farmers were using lithium chloride salt on the fields of celery. The claim being that it would prevent the development of rust in the celery. And the farmers' families were eating this lithiumized celery, and it was killing people. So there is a problem of dosage, and I mentioned that the dose that's considered as an arbitrary window is 0.4 to 1.2 milliequivalents per litre. But it's really arbitrary, and I did use the word that it needs to be individualised. And that's a concept that I know Dr. Licinio talks about a lot, not only in this particular area, but in others. You need to have personalised therapy. And it's not only with lithium, it's with other things as well. It's easier to sell a product where one dose fixes everything. But I can assure you, as your observations say, that it's got with lithium, with children, with the elderly, with people that have other medical diseases, it's got to be individualised. If not, you're in trouble. But the other thing is, sometimes you do have to go up to 1.2 or beyond. And then you've got to watch more carefully. But that's the concept of medicine. There's nothing weird about it.
Sam, I have a quick question. Do you have any ideas or suggestions as to how lithium is increasing gray matter?
That, as they say, Dr. Licinio, is a very good question to which I have no answer whatsoever, especially as the fact that valproate does have some value in treating the same condition, and it does not increase the volume of grey matter. So you're left with a very good question.
Do you think the specificity of lithium that you so vividly outlined for us can contribute at all to our understanding of the variable effects in the etiology of bipolar disorder?
Do you want to summarise the last bit, Ron?
Well, really, as we know it's so specific in its effects, what might it tell us about etiology in bipolar disorder in its contribution? I'm not suggesting for a minute a sole factor, but what etiological stream might it be acting?
The people on this side of the theatre specialise in good questions. And that's all I can tell you. It's a very good question. And I don't know what it tells us about it, but I think when we look at the matter of drug discovery, I think it's important with lithium to go backwards. That's translational research in reverse. Here is something that actually does work, and it might work specifically. Then the real question is, how does it work? And with neuroscience developing all those things that I presented in the unique features, that to me is one way to develop new compounds to eliminate some of the toxicities that do occur.
Yeah, Sam, thanks for your history, your overview, and for coming all this way. I wanted to ask if you know of any studies looking at biomarkers of like before lithium versus after lithium in a discovery-driven way to look at proteins or RNAs or hormones in the blood. What may be changing in these patients?
The only thing that I've mentioned and I've made much of, and maybe I've made more than I should have, is the differential retention and excretion of lithium. Now, if that's true, and I only know of one study that has in fact replicated that on a small sample that was done at NIMH by Jack Durrell, if that's true, then during the manic phase, the body retains the stuff till it builds up a level, and there are the mechanisms in the body that affect the retention. But when the mania breaks, you pee out more lithium than you take in per day to get rid of the thing. So it's a lead, but it's a pretty thin lead. But I don't know of another biomarker. The change in grey matter is an interesting thing, but it's not specific. It's specific lithium versus valproate, and we haven't looked at any of the other potential agents, but it's a very strong lead. Yes, Dr. Lehrer. And no good questions from you, thank you.
One of the intriguing things that you mentioned about lithium was the fact that it augments antidepressant effects in patients who have been non-responsive to a particular antidepressant.
Right.
And yet lithium is not in itself effective, or maybe I'm not correct about that, but it's not generally thought to be an effective antidepressant when administered alone.
Okay. Let me try and answer it some way. Firstly, if you use it prophylactically in bipolar patients, it's very effective in preventing recurrent depression. On that, there is little argument. The second thing is, how good is it in the acute treatment of a current manifest depressive episode? That is a matter of debate. My comments mentioned that Cade said in his patients, his group of 5 patients, he did not notice an antidepressant effect. The criticism of big studies of depression that were done in the United States, they were done in chronically hospitalized depressed patients by that big NIMH VA study. In smaller samples that you still get smaller control study samples of outpatients, you can get an acute antidepressant effect equivalent to imipramine in a controlled study. Now, the augmentation issue is pretty well established, but your question is partly right and partly is open to interpretation. That's another good question. They're not allowed. Yes, Dr. McGorry. No, I mean, you're definitely not allowed a good question.
Okay, I just want to share something actually, because I also really enjoyed the history that you described. And I remember when I moved to Melbourne, I worked at Royal Park Hospital as well, and I was absolutely amazed because John Cade had died about 4 years earlier, and there was virtually no use of lithium in the hospital, even for acutely manic patients, and they were being treated pretty much with antipsychotics alone in the acute manic phase, and it was driven by, I think, this kind of counter-reaction that you described by a group of people in Melbourne who were highlighting the real effects which were brought up, and it was really quite staggering to see. So that was one thing I wanted to share. The second thing was, it's sort of a question, but it relates to what you were saying about neuroprotection. And Hussaini Manji came out here about 10 years ago and made a very big impression, I think, in Australia. And as we were developing that prodromal or ultra-high-risk focus, which probably about a quarter of the patients progressed to a first episode of mania out of those criteria. Anyway, in general, we thought that the neuroprotection might be worth exploring in that group to see if it would reduce the risk of transition. It wasn't a randomized trial, but we did a trial of low-dose lithium, just 1 tablet a day. And Hussaini said, well, as long as you get a level of around about 0.3, you're probably in the right ballpark. And it did seem to work, but it wasn't that we didn't have a control group. It did seem to be associated with symptomatic remission and even this group of non-specific to the patient. So I think, and the other thing it showed was that they also had imaging in collaboration with Chris Pantelis's group. And the T2 rapid relaxation was much better in the group that got lithium. So there did seem to be some sort of biomarker effect for it. And we haven't pursued that properly, but I just wondered if what you thought about that and whether you think it would be worth pursuing.
Let me try and answer both parts. The first part about when you got there was no use of lithium. I got there in 52. He published the paper in 49. There was no lithium at that time. And it appears that he really was scared of using the stuff. And there was an interesting story I heard indirectly from Scow that in the 70s, when Cade became very famous for his work on his first paper, he was invited by Scow to Aarhus to give a celebratory lecture. And the title was not announced. And Cade came and he gave a lecture on strontium. So that was a little amazing. The second question you raise about Hussaini Manji's work, it is really part of what I was referring to. The fact that there's neuroprotective and neurotrophic activity, both, that has been definitely developed. And the fact that in the group of patients that have recently been published, it increases the volume of grey matter. The question that I think we're all struggling on is, what is the minimum effective dose? And there was a large grant submission in the United States for using it in Alzheimer's patients. And it actually died a death because everybody was scared of these elderly people with obvious neurocognitive deficit where would we get away with a safe therapeutic window? So the study never got started. But in my discussion with people that are more knowledgeable about this than I am, there is a strong belief that if you had the manpower to titrate the dose per patient, both in the controlled and in the blind group, you should be able to show a difference by titrating the dose up to a safe level, perfectly safe, maintaining it, and then over time doing volumetric measurements of the grey matter and seeing if that gross measure changes irrespective of the deficit group that you're looking at. And my colleague here mentioned, I will definitely stop, there is an old paper by Sheard using lithium in prisoners, assaultive, violent, people that had outbursts of violence and would calm down and be manageable. They'd get good passes, go outside, and then they'd have another outburst. And that particular subpopulation of episodic outbursts with some brain damage seemed to be controllable. I think I should definitely stop. Thank you very much.